Hello, my name is Dr. Shirish Gadgil. I'm the Chief of Division of Hematology and Oncology at Henry Ford Cancer Institute and Henry Ford Health System. Today I'm going to be discussing what is the biologic rationale for checkpoint inhibitor based combinations. I'm going to start off the discussion by presenting a patient of mine, a 60-year-old female patient diagnosed in August of 2013 with adenocarcinoma of the lung with pleural and liver metastases. The patient was treated with carboplatin and pemetrexate, but about 6 months after initiating therapy, she had evidence of disease progression. She was then enrolled on the Keynote 10 trial, which randomized patients with recurrent non-small cell lung cancer to pembrolizumab or chemotherapy. Patient was randomized to pembrolizumab and started pembrolizumab on March 15, 2014. The scan on your left represents the images of scan done on March 4th, 2014, which show the evidence of liver metastases. The scan on your right was done about a year and a half later on November 23rd, 2015, which shows almost a complete response. The patient received pembrolizumab for a total of 2 years, and since early 2016, the patient has been followed with surveillance scans without any evidence of tumor recurrence. Such sustained benefit only occurs in a minority of patients. Karen and colleagues presented updated results from Keynote 001 at ASCO 2019. This study, which was a phase 1 study with dose expansion cohorts in several tumor types, including in non-small cell lung cancer, showed that both in treatment naive and previously treated patients, tumor PD-L1 expression could predict for benefit from pembrolizumab. In treatment-naive patients, the 5-year survival in patients whose tumor PD-L1 expression was high was 29.6%, whereas the 5-year survival with pembrolizumab in patients whose tumor PD-L1 expression was 1 to 49% was 15.7%. Thus, it was clear that high PD-L1 expression in the tumor predicted for a greater probability of benefit from pembrolizumab, whereas a lower PD-L1 expression predicted for lower probability of benefit with pembrolizumab. Now, what does PD-L1 expression in the tumor reflect? And this can be discerned by looking at what is called as the immune cycle proposed by Chen and Melman in 2013. And this immune cycle starts with the release of tumor neoantigens by dying cells within the tumor. These are then picked up by antigen-presenting cells, which then travel to regional lymph nodes and prime and activate T cells within the regional lymph nodes to the tumor antigens. These activated T cells then leave the regional lymph node into the circulation and eventually reach the tumor microenvironment. Once the activated T cells reach the tumor microenvironment, they recognize tumor antigens, launch an anti-tumor immune response, and cause further tumor cell death, further release of new antigens, and thus this immune cycle can continue. However, in many cancer patients, this immune cycle is inhibited at various points along the cycle. Thus, in some patients, tumor antigens may not activate T cells within the regional lymph nodes. This could either be because the tumor does not express sufficient neoantigens that are distinct from self, or the antigens expressed do not induce a significant immune response. Such tumors are designated as immune desert tumors. Then there could be tumors where an immune response is initiated. However, the immune cells cannot reach the tumor microenvironment, and these group of tumors are designated as immune excluded. And then there is a third category of tumors, the inflamed tumors, where activated T cells do reach the tumor microenvironment and are capable of launching an anti-tumor response, but are limited by checkpoint inhibitors, such as PD-L1 expression on the tumor. It is only in the inflamed tumors that checkpoint inhibitors that target the PD-L1 PD-1 axis can induce an anti-tumor immune response. If there is no activation of T cells as occurs in immune desert tumors, or if the T cells do not reach the tumor microenvironment as occurs in immune excluded tumors, anti-PD-1 or PD-L1 agents are unable to initiate an immune response because for these drugs to act, activated T cells have to be present within the tumor microenvironment, and only then can these drugs inhibit the checkpoints and thus allow the activated T cells to initiate an anti-tumor immune response. Thus, there is an interest in evaluating strategies that can convert immune desert or immune excluded tumors into inflamed tumors so that checkpoint inhibitors that target the PD-1, PD-L1 axis can induce an anti-tumor response. Chemotherapy has the potential of doing so. Chemotherapy is known to cause tumor cell death and release of neoantigens that can be picked up by antigen presenting cells, which can in turn activate and rather prime and activate T cells to the tumor neoantigens. In addition, chemotherapy can inhibit regulatory T cells that can exclude activated T cells from reaching the tumor microenvironment. Based on these observations, studies have been conducted that have evaluated the addition of checkpoint inhibitors to chemotherapy. One such study is Keynote 189. In Keynote 189, patients with non-squamous histology non-small cell lung cancer who did not have sensitizing EGFR mutations or ALK translocations were randomized to pembrolizumab plus pemetrexate and platinum chemotherapy or received placebo plus platinum-based chemotherapy. As is well known, in this study, the addition of pembrolizumab to pemetrexate platinum-based combination improved survival with a hazard ratio of 0.56. Patients who received the combination of pembrolizumab and chemotherapy had a median survival of 22 months, as compared to a median survival of 10.7 months in patients who received placebo plus chemotherapy. This study also showed that the addition of pembrolizumab plus chemotherapy provided survival advantage across all PD-L1 subsets. Thus, even in patients whose tumor had a PD-L1 expression of less than 1%, addition of pembrolizumab plus chemotherapy improved overall survival compared to patients who received chemotherapy with a hazard ratio of 0.52. Keynote 001 demonstrated that the likelihood of benefit from immunotherapy alone in such patients was virtually negligible. Thus, the fact that combination of pembrolizumab plus chemotherapy improved survival as compared to chemotherapy suggests that in these patients, addition of chemotherapy may have converted certain tumors to a more inflamed phenotype, allowing a drug like pembrolizumab to initiate an anti-tumor response. Similarly, the addition of an anti-CTLA-4 agent may convert some tumors that are not inflamed into an inflamed status and thus allow checkpoint inhibitor targeting the PD-L1 PD-1 axis to initiate an anti-tumor response. This was demonstrated in Checkmate 227 study that stratified patients according to PD-L1 expression. And in patients whose tumor PD-L1 expression was less than 1%, randomized such patients to nivolumab plus ipilimumab chemotherapy or nivolumab plus chemotherapy. If we focus on the results in the patients whose tumor PD-L1 expression was less than 1%, what was shown was that the addition of ipilimumab to nivolumab improved survival compared to patients with chemotherapy, again suggesting that the addition of ipilimumab to nivolumab potentially converted some tumors from a non-inflamed status to an inflamed status, since in this population, nivolumab as a checkpoint inhibitor is unlikely to induce a significant anti-tumor immune response. Thus, the immune cycles helps us understand the biological rationale for evaluating checkpoint inhibitor-based combinations in advanced non-small cell lung cancer patients. Tumors of patients in general can be categorized into three distinct subtypes: an immune desert subtype, immune excluded subtype, or an inflamed subtype. Single agent checkpoint inhibitors targeting the PD-1 axis are likely to induce an anti-tumor response only in patients with tumors that have the inflamed subtype. Combination treatments could convert some of the tumors that are non-inflamed into an inflamed subtype and thus initiate anti-tumor immune response. And this has been observed with combinations of chemotherapy and checkpoint inhibitors, as well as combinations of dual checkpoint inhibitors. In conclusion, current checkpoint inhibitors are effective in patients with inflamed tumors, but not in immune desert or immune excluded tumors. Combination of chemotherapy with IO or combination checkpoint inhibitors may convert some non-inflamed tumors to inflamed tumors. Thank you for your attention.